everyone. Happy evening, a very good evening. I hope and I believe all of you are doing well. A quick note whether the audio visual is all good. Am I audible and visible? Just a minute, let me get access to the live chat. Okay, that's great. That's great. So I was just waiting for the live chat. Yes, guys. So we are starting with the series here, the short topics for the upcoming FMGE exam, and I'm sure the NEETPG students will have this query that is this useful for the NEETPG students as well? Yes, absolutely. This is useful for the NEETPG students also. So that's what I mentioned in the Telegram group as well. So the very first episode that we have is based on the ECG findings. In arrhythmias, the supraventricular arrhythmias, the ventricular arrhythmias. So the episode 1 short topics is also the episode 10 of the FAST episode. What is FAST? FAST is the first aid simplified teaching. The sessions that we have had based on the first aid before the INICT exam also. And thank you so much everyone for all the love for those sessions. Had been receiving a lot of messages post that asking for sessions on based on first aid, right? So I have already shared the PDF on the Telegram group. PDF has already been shared, Vinu, on the Telegram group. So remember that you can always annotate as you are watching these sessions. फास्ट सीरीज खत्म नहीं होगी, ये फास्ट सीरीज साथ में है, सब कुछ साथ में चलेगा, राइट? सो नहीं, Vivek, short 150 is definitely going to be short 150, right? Okay, so without further delay, let's start with today's session there. And so do we also have the offline short 150 is another query that I've been getting. Like we are having online episodes, so will we have offline also? Yes, so today itself we have announced the offline short 150 also for the FMG students, which will be basically all 19 subjects revision that we would be doing. So basically the offline short 150 has been planned in Delhi on 10th to 12th of July. This is going to be all 19 subjects and all the relevant topics, like no nonsense topics, all high yield topics and the most expected topics. So you can definitely ask your seniors who have attended the short previously that is it helpful, is it not helpful, or how helpful it is. So I'm going to put in my best to help you there. And the NEET PG students, can they attend this offline class? Yes, especially the students who are starting their preparation now. So basically this course will be like a primer course for you. You will understand, you will learn a lot of tricks. You will learn a lot of strategies on how you should be going ahead preparing for the NEET PG exam. And you would already learn so many topics that are important, like they are must know for your NEET PG exam as well. Okay? So, Mohammed Jafar, which series are you talking about? Okay? Yes. So let's start with this. I've already told you what's the page number in the first aid. If you want to annotate there, you can do that. And I've already shared the PDF also on the Telegram group. So without any further delay, starting there with the discussion of this topic. So basically here we are talking about tachycardias, particularly in this session. So we have narrow complex tachycardias and we have wide complex tachycardias, right? So what do we have basically is, so in tachycardias, if you see, it can be narrow complex, narrow QRS complex, or it can be wide QRS complex. So when you see narrow QRS complex tachycardia, basically this is supraventricular tachycardia. Ventricular tachycardias are wide. Okay, remember that ventricular tachycardias are wide. So remember V and V, ventricular tachycardias are wide. Okay, When do you call it narrow? When do you call it wide? Less than 120 milliseconds basically is narrow. What comes in the supraventricular tachycardias is the atrial tachycardias like atrial fibrillation, atrial flutter, MAT, multifocal atrial tachycardia, and also the AV nodal vale tachycardias like we talk about PSVT and the WPW syndromes. WPW syndrome that also comes here. In ventricular, we have monomorphic ventricular tachycardia or polymorphic ventricular tachycardia, that is Torsades de pointus, and we also have ventricular fibrillation. So we are going to see about this quickly. Okay. So, right, Vishwajit will be doing that as well. Okay. Chalo, let's start. So starting with the narrow complex tachycardia. So remember that narrow QRS complex is less than 120 milliseconds. And why is it narrow QRS? What does the QRS indicate basically in the ECG? QRS indicates ventricular depolarization. So basically because of the rapid ventricular activation which is happening via the normal conduction pathway, that is what gives your narrow complex. So always remember this concept here that if the ventricle is excited, is activated by the normal pathway, SA node, AV node, bundle of his Purkinje fibers, it will have the narrow QRS complex. That is what is supraventricular. If the ventricle is excited by a focus which is aberrant focus, that will give a broad QRS complex. So when we talk about ventricular tachycardia, the origin is coming from the ventricle itself. It's not from the SA node, AV node, and then it is coming. And that is why it is broad QRS. Okay, that's why it is broad QRS. So coming to the first one, atrial fibrillation. Most important point that will be given here is irregular rate and rhythm. It is irregularly irregular. So look at this ECG here. Look at the RR interval. Look at the RR interval. Look at the RR interval. So basically the RR interval is not constant, right? It's not constant. So that tells you this is irregular, right? So this is irregularly irregular with no discrete P waves because P wave is because of atrial depolarization. This is also asked in the exam. So the atrial fibrillating means the atrium is not contracting well. So remember that the P waves will not be seen. That is what you see here, irregular baseline, that is absent P waves. Okay, absent P waves. Can someone tell me that if you see regular rhythm, there is tachycardia, regular rhythm tachycardia, which is narrow complex with the absent P wave, then what arrhythmia will you think of in that case? Sanket, the Telegram group name is Dr. Nikita's Radsynapse. I can see your messages so many times. The Telegram group is Dr. Nikita's Radsynapse. So you can just search for the channel Dr. Nikita Nanwani. You will get the PDF there as well. Right, so my question is, what will be that arrhythmia where it is narrow QRS complex, but the rhythm is regular, the P wave is absent, but the rhythm is regular? Then in that case, what arrhythmia do you think of? Absolutely right, Chandani Omkar, correct? In that case, it is PSVT. Remember, that's the very important, the difference that we should know between PSVT and atrial fibrillation. In PSVT, it is regular rhythm. In atrial fibrillation, it is irregular rhythm. Okay, very, very important. Now, going to the next one, another important point, what is the focus in atrial fibrillation? What should you ablate in atrial fibrillation? That is why. So remember that the arrhythmogenic activity, it is arising near the pulmonary vein ostia in the left atrium. It is the left atrium ke wahan pulmonary vein ostium which is the arrhythmogenic focus, and that is why the definitive treatment is ablation of pulmonary vein ostia. That is basically what is the focus? Pulmonary vein going into left atrium. Okay, left atrium. What are the risk factors? The risk factors are hypertension, coronary artery disease. You will also see this commonly. The background history of alcohol predisposes to atrial fibrillation. Thyrotoxicosis. You had one of a recent question in NEET PG exam. Thyrotoxicosis also predisposes to arrhythmias including atrial fibrillation. And very, very important, remember that when there's atrial fibrillation, that means the heart is not contracting well the atrium. So that predisposes to stagnation of the blood and the formation of a clot. And that is why thromboembolism can occur and the patient is at risk of developing stroke. And that is why in the treatment of atrial fibrillation, we should consider anticoagulants. What score do we check for in atrial fibrillation? It is the CHADS-VASc score that we check for. When it is more than equal to 2 score, that is when we give anticoagulants. I'll come to that table as well. So remember that anticoagulation is given based on the stroke risk. Okay, based on the stroke risk. Okay. So that is about atrial fibrillation. Coming to MAT. First, let me tell you the important points for MAT. Very, very important. The key word in MAT would be history of COPD. A patient of COPD presenting with arrhythmias, that is when you should think of multifocal atrial tachycardia. Now, as the term says, it is multifocal atrial tachycardia. That means from the atrium, there are multiple foci which are firing, and that is why the P wave which is coming because of atrial depolarization will be of different morphologies. So that is what is the key to identify MAT. At least 3 distinct P wave morphologies because this is multifocal atrial tachycardia. Okay. So remember the underlying condition COPD, very, very important. That is almost always mentioned in the question. And you have pneumonia and heart failure. Even this is irregularly irregular. So look at this. The rhythm is irregular. And look at the P waves. Look at the morphology of the P waves that we are having here. The P waves have different morphologies. At least 3 distinct P wave morphologies makes it a MAT. Next one, coming to atrial flutter. The key word for atrial flutter is the sawtooth waves. Okay, that is a key word for atrial flutter, that is sawtooth appearance. Right. So remember that what causes atrial flutter is the rapid succession of identical consecutive atrial depolarization waves. So sawtooth appearance of the P waves is what you have. And that is, remember the difference between atrial fibrillation and atrial flutter. Atrial fibrillation, the focus was the left atrium, pulmonary vein ostium. Here it is the right atrium. That is around the tricuspid annulus in the right atrium. That is where generally the arrhythmogenic activity starts. So the treatment is similar to atrial fibrillation with or without. The ablation here will be basically in the right atrium between the tricuspid annulus and the IVC. Okay. So I hope this is clear. What are the points to be remembered? So atrial fibrillation, it is left atrium is the focus. Here right atrium is the focus. Okay, that's the difference between the two. And look at this sawtooth appearance that you are seeing here. So look at, you will see these sawtooth waves, 4 sawtooth waves, and you can see this 1 QRS complex. And if you look at the rhythm here as compared to atrial fibrillation, atrial flutter is having the regular, the constant RR interval. Right, it is more of a regular rhythm while fibrillation is irregularly irregular. Right, and also how do you differentiate this from PSVT? This sort of wave you might see in PSVT also, but it is just one wave that you would see. So narrow QRS, this wave, then narrow QRS, this wave, and then narrow QRS. So the number of wave here will be only 1. Okay. I'll be coming to the treatment part, Vignesh, right? So we are just discussing first this part, and then I'll come to some more tables, which are basically from your USMLE first aid, but the step 2 CK part, right? The clinical part of that. Okay, alright. So everybody give me a quick thumbs up if this is clear with everyone. So we are annotating the first aid as well while we are doing these sessions, and this is important for FMGE, NEET PG, IICT, all the exams. A quick thumbs up there, everyone. So in atrial fibrillation, very important point, remember the risk of stroke, and that is why we need to give anticoagulants. आ रहा है संकेत, अभी खत्म नहीं हुआ है, अभी तो हमने सिर्फ एट्रियल चालू किया है, अभी उसके बाद एवी नोड आएगा, वेंट्रिकुलर आएगा, सब आएगा. ठीक है, great. Let's go on to the next one, that is the PSVT and the Wolff-Parkinson-White syndrome, WPW syndrome. Now PSVT, basically the problem with the, what is the problem in PSVT? It is the re-entrant tract which is present. So this is also called as, instead of PSVT, sometimes in the options, if you are given this ECG and you are asked what is this, it can also be given as AVNRT, that is AV nodal re-entrant tachycardia. Okay, so basically there's a re-entrant tract between the atrium and the ventricle, and the most common is it is most commonly in the AV node. So what are the clinical features of PSVT? What is generally the history given with PSVT? It is sudden onset palpitations, lightheadedness and diaphoresis. Right, that is what the history is. Because of the tachycardia, there's palpitations, lightheadedness, right? Any arrhythmia, decreased blood supply, lightheadedness can occur. Treatment is basically by terminating the re-entry rhythm. So you need to slow the AV conduction. So it's a AV nodal wala. So you need to slow the AV conduction. So we know that in PSVT, very important, what is the treatment in PSVT? It depends on whether the patient is stable or the patient is unstable. If the patient is stable, to block the AV, we need to do vagal maneuvers, right? Like the carotid massage, if the patient is stable. If not responding to that, then the drug of choice is adenosine, right? The drug of choice is adenosine. If adenosine also is not working, then we can give calcium blocker or beta blocker. So these are the drugs basically which will block the AV. Anytime in any arrhythmia, if the patient is unstable, unstable means blood pressure less than 90 by 60, straight ahead we need to go with cardioversion, right? We cannot wait and we need to go ahead with cardioversion. Right, Krishna? This will be available after that. Yes, well, no, this is basically 2023 edition. Okay? Right, so look at this one. What you need to basically slow the AV node. So vagal maneuvers, IV adenosine is what you need to do. If the patient is unstable, then directly you will go for cardioversion. What is the definitive treatment? Anywhere there is an abnormal tract, you need to do catheter ablation. And look at the ECG of PSVT, supraventricular. So it is narrow QRS. And look at just one wave that we were talking about. Unlike the atrial flutter, where you saw those like 4 waves and then the QRS, then the 4 waves and then the QRS. Right, this will have only one wave, and the P wave might be actually absent. Okay. Going to the next one, the WPW syndrome. What is the problem in WPW syndrome? So in WPW syndrome, basically we have an extra pathway, an accessory pathway called the bundle of Kent, which is faster conducting as compared to AV node. So basically this is causing the arrhythmias. So obviously the definitive treatment in WPW will be the ablation of this tract. So in WPW, what is happening is, so let's have a look at this. This is the most common type of ventricular pre-excitation syndrome. That means the ventricle getting excited early as compared to the normal. Why is that so? Because of the fast accessory conduction pathway, which is called as the bundle of Kent. So remember, it is faster conducting as compared to the AV node. So the signal is going via this bundle of Kent, and the ventricles partially depolarize earlier. So what does it give is the delta wave. Very important. Remember, the QRS is wide and the PR is short. Understand this. So basically remember, the depolarization, the early depolarization gives the delta wave. The QRS is wide because this is the abnormal pathway which is exciting the ventricles. It is not the normal pathway. We saw in the beginning that normal pathway is narrow QRS, abnormal pathway is wide QRS. It is a short PR interval that we see in WPW syndrome because of the faster conduction, right? Because of the faster conduction through the bundle of Kent. So please remember the findings here. We have delta wave, the QRS is narrow or the QRS is broad. The QRS is broad because this is abnormal pathway. And you have the PR, which is short PR. Very important. The PR is short, the PR is not prolonged because it's a fast conduction. Right. And what is the treatment for WPW? What drug is preferred? It is prokenamide. So remember, in Wolff-Parkinson, it is prokenamide. Which drugs should be avoided? Any drug which is blocking the AV node, because if you block the AV, this bundle of Kent will get more dominance and it will win over the AV node much more. And that is why don't give the drugs which are AV nodal blocking. Which are the AV nodal blocking drugs? It is A, B, C, D. AV nodal blocking drugs are, the AV nodal blocking drugs are beta blockers, calcium channel blockers and digoxin. So remember that digoxin is also contraindicated. Digoxin is also contraindicated. Okay? Is this clear with everyone? Right? So that is about WPW. Look at the ECG here. What do you see in the ECG? This is the slow rising. The normal QRS goes like this, fast upstroke. Here it is slow rising. That is called the delta wave. The PR interval is short, right? The PR interval is short and you have the broad QRS complex. Okay, you have the broad QRS complex. So those are the findings in WPW. This is very, very important and frequently asked. So that was about the supraventricular, talking where we spoke about the atrial, the AV node wala, that is PSVT, and we spoke about the WPW syndrome. Now coming to the wide complex, wide V for ventricular arrhythmias are wide complex. When do you call it wide? When it is more than 120. So basically when the ventricular activation is slow, because the activation is coming from outside the normal system. And anything below the AV node basically comes here. So ventricular tachycardia, look at the characteristic ECG that you have here, very frequently asked. It's a broad complex QRS complex. It is monomorphic. The same morphology that we have here, that is the broad complex. So remember that typically here this is regular rhythm. This is not irregular rhythm. The rate is high. That is why it is tachycardia. And generally the background history that you have in ventricular tachycardia, a patient of MI, the scarring of MI predisposes to arrhythmias, that is ventricular tachycardia, and this can lead to sudden cardiac death. Right. The question also mentions AV dissociation because the atrium and the ventricle, they are at their own pace. So AV dissociation is what we have there. Right, so that is about ventricular tachycardia. Remember this characteristic ECG, it is regular rhythm. Very, very important. This is regular rhythm, not irregular rhythm. Next one, Torsades d pointis, which was asked in the recent INICT exam also. Right, Torsades d pointis, which is also called as, the question might mention as polymorphic ventricular tachycardia because the wave is not of the same morphology. Okay. So remember it has a shifting sinusoidal waveform. So basically Torsades d pointis means the twisting of the points. It has that party ribbon appearance. Okay, so basically I call it as waxing, waning appearance is what it has in Torsades d pointis. So look at this one. Look at the ECG here going down and then it is going up. Okay, so that is what is your Torsades d pointis. It will go like this, then it will go like this, and here it will be this appearance. So this is Torsades d pointis, and remember this can progress to ventricular fibrillation, and we know that what predisposes to Torsades d pointis is anything causing long QT. Anything which causes long QT predisposes to Torsades d pointis. And we know that there are a lot of drugs which can cause long QT. So this can be precipitated by drugs. Hypokalemia, hypomagnesemia, hypocalcemia, all low. Low potassium, low magnesium, low calcium. All of them can predispose to Torsades d pointis. What is the drug of choice for Torsades d pointis? It is magnesium sulfate IV. If the patient is stable, any unstable patient, it is defibrillation. What are the drugs causing long QT? What are the drugs causing long QT basically? So remember A, B, C, D, E, F plus NO. That is A for anti-arrhythmic drugs, B for antibiotics like fluoroquinolones, macrolides, erythromycin vagera, antipsychotics, antidepressants, very, very important, TCAs, antiemetics, antifungals, your Navir drugs and opioids. These can cause long QT. So that is about Torsades d pointis. Coming to the next one, that is ventricular fibrillation. We spoke about atrial fibrillation. Now coming to ventricular fibrillation. So you will hardly see the waves will be of small amplitude The waves are of small amplitude and there is no rhythm actually that you can see. That is what is ventricular fibrillation. You cannot see any rhythm there and the waves are of low amplitude. So this is disorganized with no identifiable waves, and remember this is fatal, and what you have to do is immediate CPR and defibrillation needs to be done. So ventricular fibrillation actually is fatal. So remember that we need to do immediate CPR and defibrillation. Okay. Going on to the next one. So this is the table that I was talking about, which is also given in your the clinical wala USMLE, the step 2 CK wala. So reinforcing the facts that we have learned. So atrial fibrillation, it can be acute, it can be chronic. Chronic may a hypertensive patient, a heart failure patient, these predispose basically to atrial fibrillation. Where are the ectopic foci? In the pulmonary veins. That means which atrium? That is the left atrium. Acute one, it is pyrates, that is pulmonary disease, ischemia, rheumatic heart disease, anemia, thyrotoxicosis, ethanol, sepsis. All of these can cause acute atrial fibrillation. We already spoke about alcohol and thyrotoxicosis. That is generally given in the question. And this one, atrial fibrillation often is asymptomatic and incidental, but it can present with palpitations, dizziness, chest pain is what the patient can have. It can lead to cardiogenic shock, and very important, it can lead to cerebrovascular accident, that is stroke, because of thromboembolism. That is what we learned. There is a risk of thromboembolism. Physical examination, the pulse will be irregular pulse. How do you identify atrial fibrillation? Look at the RR first. It is irregular rhythm and you hardly see any P wave here. Absent P wave plus the irregular rhythm is what you see. So basically no discernible P waves with irregular rhythm is your atrial fibrillation. Now coming to the treatment. If it is a chronic atrial fibrillation, the initial therapy we have to do rate control. That is AV blocking drugs. We spoke about ABCD. So you can give beta blockers, calcium channel blockers, digoxin. You block the AV. Next is anticoagulation because there is thromboembolism. Either you can use warfarin or the NOACs, the newer oral anticoagulant drugs. When do you do anticoagulation? When the CHADS-VASc score is more than equal to 2. When do you use warfarin for anticoagulation? When it is a prosthetic valve, when it is a rheumatic heart disease patient. Otherwise, in rest of the patients, we use NOACs. What comes under NOACs? Yeah, Abhi, this is not in the first aid step 1. This is step 2 CK and I've shared the PDF on the group. So if you want, you can annotate there. Can you tell me what drugs come under NOACs, guys? What drugs come under NOACs? The NOACs are basically dabigatran, which is a direct thrombin inhibitor, and we have the factor 10A inhibitors like rivaroxaban. Okay, factor 10A inhibitors like rivaroxaban. If it is unstable atrial fibrillation, obviously whenever it's unstable, you will do cardioversion. Right, so if it is an acute atrial fibrillation that is less than 2 days or unstable, you do cardioversion. Why should you do? What is the role of doing transesophageal echocardiography in atrial fibrillation? Basically, it will be done to rule out the atrial clot. So, if it is more than 2 days, that means you don't need to act very fast. It's like chronic sort of thing. So, in that case, the first thing is to rule out the clot as well. Then you will do TEE. Okay, in that case, you will do TEE. The next one, atrial flutter. Atrial flutter. Basically, what do you have in atrial flutter is, remember we have seen it is regular rhythm, sawtooth appearance is what we see, and the atrial rate is around 300 and the ventricular rate is around 150. Remember this pattern, like the sawtooth waves that you see might be 4:1, 3:1, that is what you might see there, and the treatment is similar to atrial fibrillation. MAT-ME, the most important thing that we have seen, is associated with COPD, any cause of hypoxemia, COPD. Okay, at least 3 distinct P wave morphologies is what you should see here. The history of COPD is very, very important there. Okay, the history of COPD is very, very important. Rate is more than 100. This is also to be treated as atrial fibrillation. But which drug used in atrial fibrillation will be avoided here? We will avoid the beta blockers because here we have the background history of COPD. And we know that in COPD, beta blockers are contraindicated. They can cause bronchospasm. So we will not give beta blockers here. And next one, AV that is like PSVT. And PSVT, we know that palpitations, lightheadedness is what the patient can come. The P wave might be buried in the QRS or it can come later on also, right? So basically the P wave can come after the QRS as well. And remember that here the rhythm is regular. Unstable patient cardiovert, vagal maneuvers. Remember Valsalva also comes under vagal. Ice packs, especially which we use in child with short neck. In children, ice pack is done. So, and if the vagal maneuver fails, then the drug of choice is adenosine. Okay, then the drug of choice is adenosine. WPW syndrome, we have seen that it's the accessory pathway, the faster conducting bundle of Kent is what we have. Characteristically, it has delta wave, broad QRS and the short PR interval. If it is asymptomatic, nothing to be done. What is the drug of choice? Parkinson is procainamide or amiodarone. What drugs are to be contraindicated? AV blocking drugs are contraindicated like CCBs or digoxin. What is the definitive treatment? Radiofrequency ablation is the definitive treatment. Okay, that is what we have seen here. Okay, that is what we have seen here. Now coming to the ventricular ones. Ventricular tachycardia, look at the ECG. Monomorphic is what you are seeing here. And it is wide QRS complex that we are seeing. Remember, the history of structural heart disease, MI, is generally associated. When do you call it sustained ventricular tachycardia? Remember, more than 30 seconds. More than 30 seconds. This can progress to VFib and cause death. So what do we have is AV dissociation is what we have already spoken. Again, unstable is cardioversion. The antiarrhythmic drugs, if the patient is stable, we use amiodarone, lignocaine. Remember, lignocaine is only for ventricular arrhythmias. It does not act supraventricular areas. It acts only on the ventricle, right? So amiodarone, lignocaine and procainamide are the drugs used here. Amiodarone is generally the drug of choice in ventricular tachycardias. Ventricular fibrillation, look at the ECG here, no rhythm at all, small waves. So syncope, absence of blood pressure, no pulse is what we have here. And remember that here you need to do immediate defibrillation needs to be done along with the ACLS protocol, that is CPR needs to be done. Torsades depointers, look at another ECG here, waxing, waning. This is what the pattern is what you see in Torsades depointers. And this also presents with palpitations, dizziness and syncope associated with long QT. Hypokalemia is what predisposes. And the drug of choice is magnesium sulfate, cardioversion if unstable. Right? Now let's have a look at the questions. All these are the FMG PYQs related to the topics that we have learned. So quickly tell me here, what do you think would be the answer to this one? You can see that this is a question asked in June 22. So comment on the ECG findings which are shown. Comment on the ECG findings which are shown here. Do you think this is ventricular fibrillation? Do you think this is PSVT? This is ventricular tachycardia? Or this is atrial fibrillation? Very good. So majority of you are right. And remember, the easy trick to identify especially the arrhythmia ka ECG is you should check this long strip first, jo niche diya rehta hai, if that is given, that helps you to first diagnose the condition. So if you see here, what do you see? Is it a narrow QRS or is it a wide QRS? It is a narrow QRS complex tachycardia. You can see this one wave every time. So that fits into PSVT, right? This fits into PSVT. Ventricular tachycardia will be broad QRS, right? It will be broad QRS. How is the rhythm here? How is the rhythm here? The rhythm is regular. So atrial fibrillation out, ventricular fibrillation is going to be out. Right, so based on this, you can identify that this is PSVT. What is the first step? If the patient is stable, vagal maneuvers, carotid massage. If does not work, then you go ahead with adenosine is the drug of choice. If the patient is unstable, very frequently asked in the exam, then you directly go ahead with cardioversion. If unstable, go ahead with cardioversion. Right, so remember narrow QRS, regular rhythm and just one wave in between the QRS, that makes it PSVT. Okay, that makes it PSVT. Next one, a patient complains of palpitations. Very important, it's given that it is irregular radial pulse and there is absent P wave. So all the leads have been given. This is your June 22 exam question. So what is going to be the answer to this? Everything has been given irregular, absent P wave. This is going to be atrial fibrillation. Absolutely right. This is going to be atrial fibrillation. What is the treatment for atrial fibrillation? Rate control, rhythm control, right? And you have anticoagulation that we need to do. So for atrial fibrillation, rate control, rhythm control, and we have anticoagulation. For anticoagulation, warfarin or the NOACs, we use the Chagas score. That is what we spoke about. Will lignocaine be used in the treatment of atrial fibrillation? Will lignocaine be used in the treatment of atrial fibrillation? Yes or no? Lignocaine is not used. Why? Because lignocaine is only for ventricular arrhythmias. Okay, remember that lignocaine is only for ventricular arrhythmias, and that is why we will not use lignocaine here. Okay, we will not use lignocaine here. Okay, right. Going on to the next one, and I think this is the last question, which is your December 21 question. Best treatment for unconscious middle-aged patient in the ambulance shall be which of the following? What do you think is the image showing? Will you take the patient to ICU? Will you start the CPR and defibrillation? Will you do carotid sinus massage? Or will you observe the patient? Absolutely right. It is start the CPR and do defibrillation. Why? Because what are you seeing here? No rhythm here, like no waves, like these are small waves. What is the diagnosis here? Basically, this is ventricular fibrillation. And in ventricular fibrillation, defibrillation and CPR is what needs to be done. This is not atrial fibrillation. You are not seeing any QRS complex. In atrial fibrillation, you will see the QRS complex. Okay? So start the CPR and defibrillation is what you need to do here. And carotid sinus massage is for PSVT. Okay, carotid sinus massage is for PSVT. If it was Torsades D pointers, you would have done the magnesium sulfate, right? Magnesium sulfate. This is ventricular fibrillation is what we are seeing here basically. Okay. Okay, we have one more question here. I thought that was the last one. What is the answer to this one? So this question is asked in 2017. Which of the following is correct about the image shown below? Right. So as I said, arrhythmia wala question hai. So last wala lead dekho, that makes the things easy. Look at the last one. What are you seeing here? This is the monomorphic broad QRS is what you are seeing here. Okay, this is broad QRS, monomorphic pattern. So this is going to be ventricular tachycardia. Okay, so it is going to be ventricular tachycardia. Right. Is this clear with everyone? Right, is that clear with everyone? All right. So yes, that was about the today's session, guys, in arrhythmias and ECG. So integrating with first aid as well, so that you get to for the NEET PG students as well. When you want to read first aid, this helps. And yes, an update about the offline short 150 in Delhi from 10 to 12th of July. We have pinned the link of the offline session. for registration. Remember, there are limited seats, so make sure you make the best of that opportunity. We are going to do all 19 subjects, high yield points in 3 days of that session. Okay, so thank you so much, and thank you so much for joining in. I hope you have learned out of this session, or at least this session has helped you in a quick revision and the annotation of the first aid. And yes, goodbye, take care, and keep